and talk about the insanity of the politics of medicine in the United States of America. Dr. H. Gilbert Welch is with us. He is a professor of medicine at the Dartmouth Institute for Health. He is the author, along with Lisa Schwartz, Dr. Lisa Schwartz and Dr. Stephen Woloshin, of Over-diagnosed, the subtitle, Making People Sick in the Pursuit of Health. It's published by Beacon Press. Beacon.org is the website. Dr. Welch, welcome to our program.
Thanks so much for having me.
I found this book both personally, useful and astounding, and also I think just societally astounding. Let's talk about a couple of the things in here. You talk about, for example, the change in diagnosis of, well, let's take blood pressure, for example. My blood pressure has always been somewhat what you might call high. There was a time when they didn't call it high. Now they do. The same numbers. My grandmother, when she was in her 70s, had never been to a doctor, fell, injured herself, was taken to the hospital. They said, oh, my God, her blood pressure is too high. They put her on blood pressure drugs. And in 24 hours, she went from being sharp as a tack to being senile and stayed that way for the next 10 years until she died. My father would not go near a doctor for years as a result of that. Is that the kind of thing that you're talking about here?
Well, that's part of what I'm talking about. What you're describing, we call the profession's proclivity to change the rules about what constitutes disease. And that's happened for high blood pressure, as you mentioned. It's certainly happened for who has a high cholesterol, who has diabetes, who has osteoporosis. And each of those diseases, those are diseases defined by numbers, we've changed the numerical rule over the last 20 years. But we've always changed it in the same direction, to label more people as being abnormal, literally millions more. And that's a problem, because all of a sudden that means you're telling people with milder forms of high blood pressure or high blood sugar or so forth that they have a disease, and then you're treating them. And these are actually people it's easiest to make their blood pressure too low, make their blood sugar too low. But it's only one part of the problem. And I wonder if I could just step back and at least make clear to your listeners what the basic concern is.
Sure.
And I want to say that I'm a conventionally trained physician. I teach, I do research, I see patients, and I really believe American medicine can be very, very beneficial for sick patients. Yep. Our concerns are about what we're doing to people who are well, people who do not have symptoms. And overdiagnosis is what happens when we make diagnoses in individuals who have no symptoms and who are not destined to ever develop symptoms or die from the condition diagnosed. And it's a side effect of our relentless desire to find disease early, annual checkups, screening, so forth. We're just looking harder and harder for things to be wrong.
Well, I thought one of the great examples in your book was prostate cancer. I had a physician in Portland who told me that he himself had never checked his own PSA. He was in his 50s. And he said it might be useful to determine if somebody has some sort of an infection, but he thinks that, if you're under 70, so what? And if you're over 70, so what? And I was frankly shocked by that, because every other doctor I've ever been to is like, oh my God, you got to have an annual PSA and figure out what's going on. And if it goes above 3 or 4 or 5 or whatever it is this year, then have 20 needles shoved in your butt to figure out if you're dying. What's the situation?
Well, prostate cancer is the poster child for the problem of overdiagnosis. 20 years ago, a so-called simple blood test was introduced, and 20 years later, over 1 million American men have been treated for a cancer that was never going to bother them.
This is the PSA test, it's the blood test.
Yeah, it's the PSA. And it turned out an awful lot of men had abnormal PSAs, and many of them were found to have microscopic cancers, far more than would ever suffer from prostate cancer. Now, that's what I mean by overdiagnosis. And you might say, well, does it matter? Yeah, it does matter, because most of these men were treated with either radical surgery or radiation. Roughly a third suffered side effects from treatment, generally related to bowel, bladder, or sexual functions, and a few have even died from the treatment. The problem is we all harbor early abnormalities. And in the case of prostate cancer, it looks like once you're over age 50, half of men or more have microscopic evidence of prostate cancer. That doesn't mean it's going to bother them. So we have to start thinking about the problem differently. And I want to be clear. I'm not telling people they should or should not get a PSA. I want to make sure they understand there are two sides to the story. I believe PSA can help a few men avoid a prostate cancer death. By a few, I mean on the order of 1,000 men have to be screened for 10 years for one to avoid a prostate cancer death.
And you're talking about people with PSAs over 10, like
I
really
know.
high.
I'm just talking a general population.
Oh, I see.
You screen 1,000 men, and you can help one. And you have to screen them for 10 years annually, and you'll help one avoid a prostate cancer death. But at the same time, you will need to treat 30 to 100 men for a cancer that was never going to bother them.
Right, unnecessarily. And expensively.
Expensively. And it's not that there's a real human cost to that. I look at that trade-off and I say, that's a bad deal.
Yeah.
But it doesn't matter what I think. What it matters is what the patient thinks. And I'm not arguing you got to do it, you shouldn't do it.
Sure.
I'm arguing you need to know both sides.
But here's
of the
these
story.
two weird statistics. One is that, the second leading cause of death among men is prostate cancer. And if you take out smokers, lung cancer is number one. Take out smokers, maybe it's even the leading cause. And on the other hand, in your book, you point out the average age of death in a man from prostate cancer is 80, if I recall that correctly. In other words, why are we worrying about this? I mean, most men, by the time they're 80, they're going to die of something.
Yeah, you're right. And by the way, we should be clear, the most common cause of death in men is still cardiovascular disease. You were talking about in terms of the cancers. But you're right. One of the things we have to address as we get older is whether we want to start picking causes of death or not, because the fact of death is something we're going to be dealing with one way or another.
Yeah.
But really, here, I want people to understand the trade-off of when they're well. The question of how hard to look for things to be wrong. And I'm not saying do it or don't do it. I just think they need to understand there's a trade-off. And that trade-off is if you start looking for things to be wrong, we will find them. Our technologies are so able to resolve, minute quantities, in terms of a billionth of a gram of biochemical abnormalities, and we're able to see things on imaging scans that are on the order of millimeters in size.
And yet, we have just a minute left, Dr. Welch.
Yeah.
Are we not, as a consequence of this, explosion in diagnoses, aren't we actually dropping breast cancer death rates? Aren't we dropping prostate cancer death rates? Aren't we dropping stroke and heart attack death rates associated with high blood pressure?
Well, first let me say we are. What is happening is prostate cancer and breast cancer death rates are going down. Whether that's a consequence of widespread screening or whether it's a consequence of much better treatment, a really relatively untold story in breast cancer. I mean, the real advances in breast cancer have been in treatment. And remember, the better we get at treating diseases, the less important it becomes to look for early forms of them. We don't screen people for pneumonia. Why? Because we can treat pneumonia.
Right. That's fascinating. So, wow. I'm not sure where to go with that other than to say,
well, let me,
is the annual physical still a good idea?
No. If the annual physical is an effort to find things wrong, it's not. If it's an effort to have a good conversation with your doctor about your preferences and your approaches to life, then it's a very good thing.
Okay. Dr. Gilbert Welch, MD, the author of the new book, Over-diagnosed, Making People Sick in the Pursuit of Health. Dr. Welch, brilliant book. Thank you for writing it. Thank you for being on our program.
Thank you for having me.
Good speaking.